Hello, I'm Mark Rapaport, and it's a pleasure to be asked to speak with you about some of our work looking at sex differences and depression, in particular focusing on a new approach to treatment with omega-3 fatty acids. I apologize I can't be with you in person today. And so what I'd like to do is talk with you a little bit about our research investigating sex differences in omega-3 fatty acid response in individuals with major depressive disorder and high levels of inflammation. As you know, inflammation has now been associated with many diseases, including heart disease, cancer, Alzheimer's, and of course, depressive disorder. But one of the things that's really important to recognize is that acute inflammation is a normal and necessary adaptive response, and it helps us with many different types of insults. It's also normal and necessary for things such as the implementation of the egg. However, what's problematic is a chronic inflammatory process, which tends to be destructive in many ways, and also shifts our energy utilization. If we look at inflammation in the brain, what we know is that a variety of different external factors, be it chronic inflammatory illnesses, exogenous cytokine production, cancer, and stress, will increase peripheral cytokines. And these increases in peripheral cytokines have central effects in terms of anhedonia, cognitive problems, fatigue, and depressed mood, as well as pain. What we also know is that there are sex differences in terms of the immune system and immune response, with women having a stronger immune response than men. So women more swiftly recover from infectious diseases, have greater efficacy of vaccines, and better cancer survival. But the disadvantage is that women are also more likely to have higher expression of pro-inflammatory genes and higher levels of inflammatory cytokines. And as you see here, a greater prevalence of a variety of autoimmune disorders, be it Sjogren's syndrome or SLE or autoimmune thyroid disease or scleroderma, just to name a few. So we see true sex differences in terms of autoimmune diseases with women versus men. If we look at sex differences in depressive disorder, what one sees again is that men and women are really quite different. Women have twice the prevalence of depression than men. They tend to experience higher symptom severity and have a more favorable response to selective serotonin reuptake inhibitors, particularly in the premenopausal periods of life. Women and men differ in terms of our understanding of anatomy of the brain and differences in neuroplasticity, with differences in terms of hippocampus, differences in terms of neurogenesis in the hippocampus, and abnormal prefrontal limbic sort of connections that are different from what we see in men. There also are differences in terms of the transcriptional signature in the brain for women and men, and also differences in the immune signature associated with depression in women and men. So what we see again is that there is a true sex difference when it comes to depressive disorder. We wanted to focus briefly and have for a number of years, in terms of our own work, on omega-3 fatty acids. Western diets tend to be very high in N6, omega-6 PUFAs, corn oil, peanut oil, red meats, and others. And that increase in omega-6 is associated with an increased rate of depressive disorder, as well as an increased rate of a variety of inflammatory conditions. N3 fatty acids tend to be associated with the resolution of inflammation and a decreased problem with depression and other inflammatory disorders. One of our first subjects looked at whether or not omega-3 fatty acids could be used as a monotherapy in garden variety depression. We had 155 completers of this study who had major depression and had a baseline Hamilton depression score of greater than 15. We also had a variety of biomarkers that we looked at, in particular, the IL-1RA, IL-6, hsCRP, and then we looked at adipokines. We looked at leptin and adiponectin in particular. And we'd hypothesized that individuals with increased inflammation would be those that responded to omega-3 fatty acid treatment, and in particular treatment with EPA. One of the key things to realize when you look at biomarkers like this is that although for hsCRP, we have a very clear definition because of the CDC and American Heart Association work of what inflammation is, which is greater than or equal to 3 on measures of hsCRP. But from other types of measures like IL-6 or IL-1RA, there are no accepted standard measures. And what one really needs to look at is one's data, which tends to be non-normally distributed. And it really suggests that one has to be careful about what one is considering to be abnormal and inflamed, because the majority of individuals have either very low levels or no measurable levels of these cytokines and cytokine receptors or antagonists. If we look at leptin and adiponectin, what you see again is that there are clear sex differences. And one has to take that into account when one looks at data in this area. Unfortunately, frequently, people do not take into account the sex differences in leptin and adiponectin levels. If we looked at the correlations that existed for women looking at BMI, hsCRP, IL-6, IL-1 receptor antagonist, leptin, adiponectin, what you see are very strong correlations amongst these various adipokines, cytokine receptors, hsCRP, and BMI. The ones in yellow are all 0.5 or greater, and as you see, there are a lot in yellow. And what you also see on this page is that all of them are statistically significantly correlated. In contradistinction, if you look at the men in this study, you see a very, very different picture with far fewer correlations of 0.5 or greater associated amongst these measures. And in many cases, what you see are really a lot of correlations that are very, very weak, if present at all, and certainly not statistically significant. So men and women are different when it comes to these measures. If we look at the results from the study, what we see when we separate out men and women is that women are much more likely to have 4 to 5 of these biomarkers of inflammation versus the men. And in general, women, particularly obese women, have very, very high levels of these biomarkers, much higher than men. And what we see when we looked at treatment response was that individuals with 4 to 5 biomarkers of inflammation that were high had a much more robust response to EPA than they did to DHA or placebo, and the vast preponderance of those individuals were women. This led to the first UG3 grant that was ever given by anyone within any of the institutes within the NIH. It was given by NCCIH to Emory and Mass General. I was at Emory at the time in the PI. And it was a 4-arm study of placebo, 1 gram of EPA, 2 grams of EPA, or 4 grams of EPA for 12 weeks. And what we saw when we looked at our baseline variables again was that men and women differed. In our sample, women had much higher levels of hsCRP than men. What we also saw when we looked at baseline values, when you look at mitogen stimulated values, what one sees is that women had a blunted mitogen stimulated response when we looked at IL-6, when we looked at TNF-alpha, and we looked at gene expression of TNF-alpha, had a much more blunted response to these mitogens than men. This is suggestive that their immune system, and if you look at the plasma levels, you can see it, though they don't reach statistical significance, but come close, that women are intrinsically more activated in terms of these markers than men, and therefore have a decreased mitogen stimulated response, which you expect to see. Our group and our interest in omega-3 fatty acids is based on the fact that omega-3 fatty acids are the backbone of the resolution of inflammation. They're the backbone of the production of resolvins and merancerins and positive resolving lipoxins. And so we did a study where we contrasted, as I said, those different doses of omega-3. And what we saw when we looked at these groups is that these pro-resolving mediators, 11-HEPE, 12-HEPE, 15-HEPE, were all correlated with a decrease in hsCRP, and that this effect was driven by the women in the sample versus the men in the sample. When we looked at plasma TNF-alpha and we looked at the presence of resolvin E3, we saw again that this positive effect in terms of decreases in plasma TNF-alpha were associated with an increase in women of resolvin E3, one of those substances we talked about earlier that were associated with the resolution of inflammatory states. If we look at the correlations amongst the specific pro-resolving mediators, markers of inflammation, what we see are different patterns again, with there being much tighter correlations between these measures in women than there are in men. And what one sees in men with these shades of blue is areas where there's less strong correlations than we see with the women. In our study that we just talked about, looking at the 4 different doses of placebo and 3 doses of omega-3, what we were able to demonstrate was that the high dose of omega-3, 4 grams a day of EPA, was associated with a statistically significant decrease in levels of hsCRP, and were associated with a statistically significant increase in an SPM 18-HEPE. And what one saw with the responders was that level of HEPE was at a level of 2,113 versus 466 in the non-responders. Unfortunately, we're running out of time today, so I had to summarize these findings for you. But what we see is similar to our previous study. Baseline levels of hsCRP, plasma cytokines, and such varied by sex, with women being different than men, and women having significantly higher levels of hsCRP. We also showed that these sex differences in association between BMI and inflammatory cytokines, and also SPMs, were different for women than men. when we looked at our 4-gram-a-day sample in the study, the effect was primarily driven by women who had a 75% response rate versus a 25% response rate for men, i.e., a sustained response at weeks 8 and 12 of greater than 50% reduction in the depression measures. What we also saw, and unfortunately we don't have time to go into the information in detail, was that increased response in women was associated with a significantly greater increase in level of EPA, despite the fact they're all getting 4 grams a day. They were also associated with a statistically significant decrease in plasma hsCRP in women versus men, and a significantly greater increase in the specific pro-resolving mediator 18-HEPE for women as compared to men. So in summary, what we've seen with our data is that there's a subset of women with major depressive disorder who are more likely to have elevated biomarkers of inflammation than men. This suggests that there may be sex differences in response to high-dose omega-3 fatty acids. And that these are really intriguing preliminary findings, and what we need to do are much larger confirmatory studies. Thank you very much for your time and attention today. I apologize that I'm not able to be with you in person, but I hope what you've been able to discern is that one of our lines of research, and one of the things that we're very interested in, are these differences between men and women, both in terms of major depressive disorder, but also in terms of inflammatory depression. Thank you again. Bye now.